Hello, everyone. Thank you so much for joining us for another episode of Stories of Care, the podcast that looks at the intersection of healthcare equity and infection prevention and control. Today, we have an exciting episode that's looking at some of our favorite germ carriers in the world, little kids. And to help us discuss that topic, we have Dr. Joseph McBride from the University of Wisconsin here to discuss what it means to do infection prevention and control in a pediatric population. Hi, Dr. McBride. It's great to have you with us today.
Hello, thank you so much for having me.
Well, I'm excited to learn about this population that I personally don't work with that often because I am an adult infectious disease doctor. So pediatrics is a whole different realm of the world.
There is, yeah. They're a unique population that gives us a lot of challenges, especially in infection prevention areas.
And well, to start us off, tell us a little bit about your story. How did you get into this world?
So I am a adult and pediatric infectious disease physician. So I did a med-peds residency at Loyola and then came to the University of Wisconsin for both of my fellowships. And I think a lot of people in med-peds have a hard time going back and forth and really choosing one. And I think infectious disease is a wonderful opportunity to work in both fields of internal medicine and pediatric because so much of what we do translates in both parts of those medical specialties. And, infectious disease in general, so much more than just an age and its exposures and risks and communities. And because of that, med-peds background, I think it really lends itself well to things like infection prevention.
No, that's so true. I remember when I was in fellowship, we would end up going into the pediatric area, especially for our transplant, because we really didn't have a separation there because it just kind of glides from one age to the other, right?
True. And especially in pediatric infectious disease, there's not a ton of pediatric infectious disease physicians. So depending on where an adult infectious disease physician might be training, it wouldn't be uncommon to have pediatric related issues or questions go across their desks or emails or infection prevention related activities. So yeah, it's good to, even if you don't see pediatric patients on a regular basis, think about these topics.
Yeah. Well, when we're talking about infection prevention and control, this population also presents rather a very unique situation. With adults, it's a lot easier to kind of probably grasp what might be happening before they come in the door, or even to instill things like, hey, wear a mask. But how do you do infection prevention and control with a pediatric population, especially in a clinic setting where you're going to have people coming in and out of the door all day?
Absolutely. It is incredibly challenging. So you need to have good protocols already in place. And a great example of this is the recent measles outbreaks that have come across the United States. So I do pediatric infectious disease and pediatric infection prevention at the American Family Children's Hospital here at Madison, but I'm also the medical director of our sister hospital, Unity Point Meriter, for their infection prevention, both adult and pediatrics. And when the measles outbreak started to come up and we wanted to put more attention to this, there was a lot of discussion about saying, all right, with fever and rash, let's immediately go somebody down into the measles pathway and have these isolations and our airborne precaution rooms ready. And we're going to be ready for our measles cases because, fever and rash is a pretty distinct finding.
Yeah, that never happens in a pediatric population.
Oh,
never.
Right, exactly. So, I think any pediatrician or anybody who thinks about kids in general just knows how that is an impossible task. And to say every fever and rash is going to be evaluated for measles at the door or at scheduling really sets you up for failure. And so, how to work it in pediatrics is I think you really have to go more than just fever rash equals measles rule out. And because of that, I think a lot of clinics and staff feel like they're behind the eight ball because exposures and risks happen just as soon as people, come through the door.
Well, and how do you do things like even just the simple things or what we think of as simple, like hand hygiene and masking? How does that work in this population?
So masking, of course, all of us who have lived through COVID and tried to navigate this know it's really impossible for young children to wear masking for control. I think you'll have some kids who take to it pretty well and are used to it, but the younger children, that's an impossibility. So I think the first thing to tell a lot of people is it might not even be worth trying, for these younger kids. And you'll see all sorts of signs at other places like, less than 2 years, less than 4 years, masking not required, in these kind of settings. So it's really to try to understand what the expectations are for age appropriate risks. But at least here at University of Wisconsin and our sister hospital at Meriter, during respiratory viral season, we really relied heavily on still using source control for our patients in certain high-risk settings. So I think as you're designing your own infection control practices for your own individual clinic, get a sense about what the patient population that you're seeing is. And so even though a lot of our COVID protocols have started to come down, we still have some more higher risk clinics, like things like HIV clinics, our hematology oncology clinics, our rheumatology clinics, immunology, individuals that might have primary immunodeficiencies. And so for these clinics, we still use things like source control for all patients who come into the waiting room and so forth. So having good understandings and expectations when that patient walks through the door with signage and is really quite important.
Well, and then how did you do this going back to your measles outbreak situation?
So it's, of course, especially something like measles, almost a near impossibility, right? I mean, it is such a transmissible virus that people walking through the door with it, even if they have source control on, might not be enough. So getting people who have these signs and symptoms rapidly assessed and moved out of the waiting room into a particular high-risk area that has negative pressure in the clinic would be ideal. But of course, many clinics don't really have that. So rapid triage is incredibly important. So what we did in our clinics here is that if a pediatric patient does have fever and rash, which is incredibly common, of course, the follow-up question is, have you been exposed to measles? And so that ideally would work. Of course, we know that doesn't always work, and people don't know that. You could also have 15 other questions that go behind that. Have you traveled internationally? Are you, completely vaccinated? But with each additional screening question that you have, it's harder to get good information back. Maybe an individual doesn't know if they've been fully vaccinated, or maybe somebody doesn't think that their trip to the UK was a high-risk trip for international travel for things like measles exposure. So we try to keep it short and quick, something that even somebody who might not have medical training like a scheduler would be able to assess and triage rapidly.
So tell me a little bit more about the outbreak that happened where you are. Do you have a large population of pediatrics or a large pediatric population rather that is unvaccinated? What was it that really facilitated the spread and kind of what happened with it?
Yeah, so in Wisconsin, our MMR rates for our kindergartners hover right around 90%. So it's really dropped significantly over the last 15, 20 years. Wisconsin always had really good levels of immunization. So it is a big area that we're trying to reach out and improve a lot of our standard childhood vaccinations. In our state, there was one measles case, just one. And yet, the amount of legwork that required from all this was really astounding. The amount of individuals that had contact tracing for this was incredibly high, well over 1,000. This individual went to multiple different medical centers throughout our state and was evaluated. And so it was a large exposure. In Chicago, of course, we're right next door, and they had a really significant, measles outbreak too. And so in the setting of all that, we were really prepping and waiting to see if we would have more cases ourselves. And, thankfully, at this point, we've kind of missed that. But it's certainly on the forefront of our mind when we see higher cases in other part of the country because, of course, it can travel.
So it sounds like your infection prevention and control methods were effective.
Well, somebody's were, yeah, right. So at least coming to us, we didn't see after that one case really any fallback, which was wonderful.
What are some of the things you do on a standard day, even without having that scare in place? What are some of the precautions you take, even with just given, RSV season, like you mentioned, during flu season, you try to have people masked in other parts of the hospital. With children, it's harder. So during, for instance, high rates of respiratory virus season, do you have different times that you see sick kids versus well kids so that way you can kind of separate them? What are some of the techniques that you use?
So we don't have a particular time for a lot of our sick kids versus young kids. It's a really large institution, so to be able to
Mhm.
kind of have a blanket statement like that would have been really challenging to do.
Mhm.
But individuals who have smaller practices, that might really be a good thing to consider. Whether you have your follow-ups in the morning and then a break and then the sick kids in the afternoon, that would be really ideal. And again, if you were in a perfect situation, you had the ability to design your own infection prevention for a smaller institution, you would have a sicker waiting room or maybe an immune compromised waiting room where people could be cohorted out. But of course, that doesn't really happen.
What are some of the specific things that you've been able to carry forth after COVID that has really been effective?
And what's really tough is what really defines respiratory viral season. I think we all kind of know it's, November, October-ish till the springtime-ish, but that really changes. And when thinking about using source control, there are really two strategies I think we were considering. One is to say every year on October 1st or November 1st through March 31st, we will do this moving forward, and just having an expectation that this is the time frame. And then the other approach is, of course, let's follow the numbers. And if we see the numbers in our community going up, then we'll escalate and make sure that we have the source control masks that are on. And that's what we elected to do, is to try to use our local epidemiology to influence our infection prevention practices. And I think it worked okay, but the feedback that we got from that essentially was people were unsure of what the plan might be or how quickly would we change. What if our numbers drop really quickly in December? Would that mean we'd take it away? And so moving forward, I think we might change gears and really got to go to more of a defined seasonal area, and then increase our levels outside should we need it.
And for your staff itself, when you come up against, I mean, standard precautions, I imagine are very routine for everybody there. But when you come up against a unique situation like you're talking about, how is your staff able to respond to the different types of precautions that might pop up when a child comes into the waiting room and they're like, oh no, or even if you're in the middle of the visit and you suddenly think, okay, this person, we need to take more precautions on, they have something that we want to prevent spread on. How do you handle that?
Having well-defined and clear protocols are really important, so that when staff are identifying an individual who, hey, this might be a respiratory viral infection, or hey, this person might have C. diff diarrhea, or oh, this might be a measles case, that staff know exactly what to do and where to get the supplies they might need. And then lastly, if they don't know what to do, where to look it up. So often we hear questions from clinic about, I know that there is some sort of C. diff outpatient protocol for sporicidal, but I can't find it. Can you help us? So we're really working on improving our access to our clinics to find our protocols on, the intranet or other areas that they be able to look up and access quickly and easily. So accessibility and clear protocols are really important.
And when you're in a situation, I mean, what I hear and what I see all the time from my colleagues is when you are in a pediatric clinic, you have parents who they might bring their other child with them for a visit, whether it's an urgent care or a well child visit, because they don't have childcare or it's just easier to do. If you're in a situation like that and you discover somebody has varicella, they need to be on airborne precautions or measles, like you'd mentioned. But the other child, I mean, what do you do with the other child?
Yeah, it's really challenging. So in that situation, if we're really concerned that this individual had varicella, well, then of course we have to consider this patient, the patient's sibling as a contact, and have to, act appropriately. So having 4, 5, 6 kids in a room is something that's really common.
Gosh,
Yeah,
can't even imagine fitting that many.
right. Yeah, so you're absolutely right. It's a unique set of challenges that are in place. And with large group, of course, you're going to want to try to cohort them all together.
So does it suddenly become you go from having one patient to 6 all of a sudden?
Exactly right. Yeah, right. It's not uncommon. And I think a lot of pediatric offices probably know where the back door is located a lot, so there's another thing to just, again, if you were designing your own outpatient clinic or you had a smaller practice and you had the ability to have an exit in certain locations, it could be really helpful for getting people out without walking through the waiting room, or having somebody come in for a quick swab at the door without going through the waiting room. So there's a lot that you can do with back doors, going into parking lots in pediatric clinics.
Well, so that brings up the whole structure of how we design clinics. I mean, it's a topic of conversation that has become very popular over the last couple of decades. How
Yeah.
can we design clinics in a better way to increase functionality, increase efficiency, increase team play? But what about to increase infection prevention and control? What can we do there? You mentioned a back door.
Yeah. So there are two, I guess, sites that I would look into. One is called ASHRAE. That's the
Yeah.
American Society of Heating, Refrigeration, and Air Conditioning Engineers, and they have healthcare guidelines that I think are really helpful for, again, I have a small pediatric clinic. I've got a private practice. How can I best optimize my HVAC system? And they've got really good recommendations there too. Of course, there's also APEC guidelines as well too. APEC is the Association of Professionals in Infection Control and Epidemiology. They've got really good clinic-based resources about what to think about when you're designing your own clinic. Some really kind of helpful stuff to think about that they go into are stuff that oftentimes you forget, like carpet. Like probably
Oh,
not the best thing to have, shaggy carpet in your clinic waiting room spaces or your hallways that could really capture those fomites, or having high touch surfaces that are easily cleanable. A lot of
yeah.
pores and things like that. When you think about a pediatric waiting room with things like Legos and, you know,
Mm-hmm.
stuffed animals and stuff like that. Those are probably not the best things to have in your ped waiting room. So they have a
Yeah.
really good guideline that have a lot of practical information that doesn't require a whole major renovation to really optimize your infection prevention in the outpatient setting.
We just chose a new carpet for our house, and now you're having me
Is that
question
right?
whether I made the best infectious disease
Right,
decision.
right. Yeah. Well, you probably have symptom screening on a pretty regular basis at home.
There
So,
you go.
yeah, right.
There you go. No, the entire main floor is no carpet, just for that reason.
Just for that reason. Yeah.
That reason and the dog.
Sure. Yeah.
Yeah. Well, and how about in places where you're coming into a pre-designed office? I mean, a lot of our hospitals and clinics have been around for a long time.
Right.
How can we, what are some of, I guess, the non-negotiables that we need to do to optimize those spaces?
I think a really important non-negotiable is some sort of symptom screening for individuals, especially if they're going to be coming into a really large waiting room. And so that
Mhm.
would usually mean checking in at the front desk or a kiosk or however it is. Now we've really started to narrow it down to um, do you feel sick? Do you have fevers? Do you have rash? Rash was added in the setting of the measles, and we likely will kind of take it away as our number of contacts goes less and less. But that the ability that we can bring those back up. Also during the Ebola outbreak in Central Africa, we were asking people about travel related questions too, of course, if they'd been to Central Africa at all too. Or a couple of years ago when the Mpox numbers were up, we were asking about specific rash questions. So I think having protocols in place to maybe add or subtract particular screening questions could be valuable depending on the patient population that you see and the different epidemiology of infections that might be out there.
And once you get past that stage and you're in the room like we discussed, and now you have to switch between patients. How do you make sure a room isn't going to be a purveyor of the viruses or the bacteria that might have been there from before? I mean, we don't have the time like we do in the hospital, have a whole EDS
Oh,
staff
no.
come in and do
Yeah.
what they need to do, right? So how do you take care of this?
So there are two things that we say in the outpatient clinic. One, infection prevention is everybody's job, but yet also you need to have really clear, defined roles. If you think it's everybody's job, you have the ability to think, well, I'm not going to be the one that has to wipe this down, or I'm not the one that
Mhm.
has to clean this room or manage it. So um, each individual who works in the clinic should know what their particular roles are and to do them. And if you find that there are holes in that, anybody else can, of course, take its place in that. So we do have two ways to think about cleaning rooms. Of course, there's the cleaning room, and then there's disinfecting a room. And so between patient encounters, if there is not any sort of known risk of a communicable disease or, we will do a lot of cleaning of the room. But in generally situations where might be a C. diff or a respiratory virus or, certainly things like, measles, of course, that would be cleaning and disinfection. And then each day at the end of clinic, we have a cleaning staff that comes through and will
Mhm.
the more thorough cleaning and disinfection in all the rooms as well.
Everybody is so understaffed in the healthcare world right now, and time is, things are demanding to be done, more patients to be seen in a short amount of time, and it just seems like there's just so much to do. How do you how do you balance that with your staff so that way if there is a moment that pops up like a measles case or a varicella case that needs a more thorough cleaning between two patients, how are you able to help fit that into the flow without people feeling overburdened?
I don't know. I think if you find a good reason, let us know. I think people feel incredibly burdened by these things, and I worry a lot about a lot of the email communications that we tell clinics. It seems like almost on a weekly or bi-weekly basis, we're asking them to do more or change out this screening question, and I think it is quite overwhelming. I think the best way that we can do it is having clear and concise communication, and then providing the data that we have and the lack of data that we have and where to find answers all in one good piece of communication. So, all right, we're going to be updating our C. diff protocol. Here is the link as to where you can find these resources. These are why we are doing these things all at once. But you're absolutely right. I think it is a big barrier. And when we look at retention rates of things like medical assistants and schedulers, it's not particularly high. And so we have to improve that a lot.
You were discussing earlier some of the source control things that you can do from the staff side, and with issues around declining vaccination in the community, in the rates, I mean, in the
Sure.
sense of you mentioned 90% now vaccinated rather than what you used to have in Wisconsin. Do you have any vaccination rules for source control in the clinics themselves to reduce that spread of the pediatric diseases?
We at our institutions do not, but I know that many institutions do. And it's not unheard of to hear of pediatric clinics that don't accept patients who are vaccinated. And so
Really?
it is something that you will read a lot about and hear a lot about. And the rationale is just what you'd expect the rationale to be. I'm concerned about the spread of communicable diseases in my clinic based on an unvaccinated population. Or I'm worried about being able to really reach and communicate with these cohort of families who choose to be unvaccinated. Those are really the two biggest arguments you hear. The other side is very compelling too. This is a patient population that we need to reach, that we need to really embrace with as much of connection as possible. Being unvaccinated is just kind of a snapshot in time, and you never know, how many conversations down the line it's going to take to have that or to make that impact. So this is stuff that you will read about and hear about is limiting clinics that have this. But us here at UW, we don't have that kind of restriction at all.
It's just fascinating given the population you work with and the different risks that they present. So, I mean, I have a good friend who she's now a med peds specialist herself, but
Yeah.
she grew up in a household where pediatric vaccination was completely taboo. And so now she's on the other side. She's like, if I can use my experience to try to reach out to more people and help them understand that's really one of her big goals.
That's
And I think
really
it's very admirable.
right. And that's a perfect example of why I really worry about the approach of not embracing these families with more of a welcoming attitude, is that you never know how that's going to turn out and down the line. So that's a really interesting story.
Yeah. No, I agree. I mean, I'm in your neighboring state of Iowa, so we have a lot of the same kind of demographics and I think some of the same experiences when it comes to people having concerns and questions surrounding vaccine before they jump in. So you definitely just have to keep on having those conversations. And one thing I keep on trying to tell some of the providers that I work with is, they might not do it today, but don't cross them out for good. Keep
Right.
on trying. Just keep on having a little bit of the conversation, a little bit at a time. And I think that's something that people are getting fatigued of having those conversations, but it's so important.
Yeah, right. It really is.
Mm-hmm. And in Wisconsin, I know that you also have some other populations that probably open themselves up to the world of not having had exposures to vaccines, like some of the immigrant community and the refugee community. How does that play into everything that you all are doing?
That's a great question, and it's something that we're always going to be challenged with. Um, Here, we've been really eager to get language appropriate documentation and signage up for people during respiratory viral season. So for us in Wisconsin, it'd be English, Spanish, Hmong populations. You will see different language signs, so people knew, regardless of what language they might speak or read.
Mm-hmm.
We had a large challenge of this when a lot of Afghani population came after the fall of Kabul a couple of years ago. We had good signage for this large group of individuals who are coming here. So working and adapting on how we can get language appropriate materials for people so they know what to expect was a unique challenge for us.
And having more of an influx of refugees and immigrants, has that increased your relationship and you're working alongside public health more because they're probably doing a lot of interventions in the community?
Yeah, we have a really close relationship with our public health department here. I think even before, the pandemic, it was pretty good. But in the setting of there, I think, I'm just looking at my telephone right now and trying to think of how many public health workers numbers I have in there. So yes, especially if you are kind of in a standalone clinic and you're looking for help, what an excellent resource. They're always so eager to participate and help.
Well, this has been such an enlightening conversation taking us into the world of pediatrics. Anything that you want to leave the audience with your last message for today when they're considering infection prevention in pediatric population?
Keep on fighting the good fight. It's not perfect. Peds is snotty, it's messy, it's dirty. You get cough and vomit and stool and all that on you. So it's incredibly hard. It's you will get your hands dirty, literally, but keep up the good fight. Keep on doing what is the right thing with infection prevention, and know that your efforts are not unrecognized and are making a difference.
Well, couldn't say it better myself. So thank you so much, Dr. McBride, for joining us for this conversation today. And thank you to all the pediatrics populations out there who are really taking care of trying to prevent spread one patient at a time, or sometimes 6 at a time.
Well, thank you so much for having me.
Stories of Care is a publication of the AMA and CDC's Project First Line. Project First Line is a national infection control training collaborative working to provide all healthcare professionals with the foundational infection control knowledge they need and deserve to protect themselves, their patients, their coworkers, and their communities. For more information, trainings, and other infection control resources, visit cdc.gov/projectfirstline and amafirstline.org.